I'm going to see if I can share my screen with the time that Dr. Ferrer gives us.
We have a lot of questions.
While I'm pulling this up, let me see if I can answer some.
Okay, so there is questions about tumor, about the surgery. So about the surgery, probably we need to talk with Dr. Ferrer.
And about the tumor as well. Or maybe while I don't know, maybe while doctor is not here, we can ask questions about the statistics on this type of treatment, success rate. Do you have any numbers available to look at the success rate? And by success rate, I mean the one surgery with no complications.
Yeah, sure. So I don't want to, so the difficulty in my position is, right, I have my thinking of this type of treatment. Dr. Ferrer, I don't want to speak out of turn.
Okay.
There are two main ways that we can remove this tumor. One is through the nose. That's a transsphenoidal surgery where we use specialized cameras called endoscopes, where we actually go through the nose without an incision on the scalp to remove the tumor. The other way that we can remove these tumors is by actually opening up the skull, make an incision in the scalp, opening the skull, and then removing the tumor from above. So we can go through the nose, or we can come from above to remove the tumor. Okay. Both have their advantages, and I don't want to speak out of turn. I'll let Dr. Ferrer talk to you about different treatment options. But the goal of either one of those procedures is to safely remove as much of the tumor as possible. One, so that we can decompress. So the biggest part of this tumor, they're pushing on some of the vital structures, specifically the optic nerve that's going to your right eye, and then the blood vessels that feed the right hemisphere and the left hemisphere of your brain as well. So we need to remove the tumor to decompress that optic nerve safely so that you don't lose vision, and then to remove it around those blood vessels without damaging those blood vessels. And we can do that safely from below and above, but the goal of the procedure is to remove as much as possible safely. So if we can remove all the tumor, and it's a benign tumor, then the risk of it recurring or coming back is very, very low, probably less than 10%. If let's say we get 80% to 90% of the tumor, sometimes we can't get all of the tumor because it's involving the bone and the dura that's covering the brain and the nerves, and it's just not safe to remove 100% of the tumor. Then we have to leave a little bit behind, maybe 5-10% of the tumor. If it's a benign tumor, then we just watch it with serial MRIs for a couple years. And if there's no growth, then we can space out those MRIs every 5 years. If it comes back as not benign, maybe a little bit more aggressive, but not malignant, sometimes we offer radiosurgery in addition to the surgery. And the radiation helps control the growth rate of the tumor. And what we found that with radiation, it can actually control the growth very well in the long term, so that you don't need any additional surgery in the future. If it comes back as more malignant, meaning it's very aggressive, then we have to talk about upfront radiation after surgery immediately to control that tumor, and then we'd have to follow it carefully to make sure it doesn't regrow. And then if it is more malignant, then they do recur, and then we have to deal with that down the road. We can't tell you ahead of time exactly what it is. A goal of the surgery is to obtain tissue to get a pathologic diagnosis to determine exactly what the tumor is and what are the biologics of what the biologic activity of the tumor is, and that way we can tailor the treatment options that's best for you. Okay. The goal, really, what the symptoms that you're experiencing now, typically we say that you will have those symptoms after surgery as well. Sometimes they may be a little worse, but they tend to get better. The goal is to make sure that your vision doesn't get any worse. Okay, you still have that right visual field vision loss in that right eye that may be permanent. Okay, sometimes when we decompress that optic nerve, though, sometimes that vision does improve.
Does improve.
Sometimes.
Sometimes.
Sometimes not.
Okay. So can you tell?
And I can't give you a percentage about that. It's everyone is it's different. Every tumor is different. So I can't give you an exact percentage of that.
How big is a tumor?
Well, yeah. Let me see if I can pull this up here.
And is it difference between this size of the tumor and the way you will perform the surgery? So if it's too big, then how you will do it? If it's kind of small?
Yeah, that's a good question. Yeah. Can you see my screen?
Yes.
Yes.
Okay. Is this, just to confirm, this is your name up here? I don't want to be presenting the wrong patient.
Yes, it's my name, Ivanova Ekaterina Nikolaevna, yes.
That's you. Okay, very good. So these are slices of your brain here on the left, sort of cutting you sliced like this. And then this is a coronal view on the right, slicing you through, like coming this way. Okay. So this enhancing portion, this is the tumor here. And this white portion is the tumor here.
Yeah.
This is the right, on these images, right is left and left is right.
Okay.
So this is the right side of your brain.
Yeah.
This is the right side of your brain. And I will show you. So here are the blood vessels. They're really being pushed on the outside of the tumor. And your optic nerve is right in here. So there's a little bit of tumor that's surrounding that optic nerve. That's the nerve that provides vision to that right eye.
So what the chances to remove safely this tumor around this optic nerve?
It can be done. It really depends on what the consistency of the tumor is. Most of the times these are just little fibers, and then we can safely remove it. It just all depends when we get into what the consistency of the tumor is.
Okay.
And I'm going to give you a measurement here.
Yes, please.
So it's about 2.2 by 3 centimeters.
It's a big one.
It's fairly sizable. There is, you see here, the reason you may be having some headaches, this stuff around here, that's just some swelling. That's reaction from the brain tissue itself. And so this may be causing your headaches, and then may be related to those sensory changes that you're experiencing as well. Tough to tell, but anytime we see this, that's just some irritation within the brain from the tumor itself.
So the tumor is pushing on a brain, and there is some irritation going on.
Correct.
How are you going to address that irritation spot? Is it going to go away by itself, or is it?
Yeah, so I'm going to come out of this screen just so I can see you. Yeah, so that's a good question. So sometimes that's just a reaction of the brain to being compressed from the tumor itself. Sometimes there's a portion of the capsule of the tumor that actually invades the brain tissue itself. So that swelling will go down after the tumor is removed. And sometimes upfront steroids or steroids after surgery can help with that swelling.
Okay. Is it possible to figure out how long this tumor have been growing there? We believe that these are relatively slow-growing tumors.
I don't want to speculate as to what type of tumor this is, but given its appearance and location, it looks like a meningioma, which is a tumor of the dura that covers the brain. These are relatively slow-growing tumors, so I suspect you've had this for several years, and it's finally just presented itself after getting to a critical size, pushing on the critical structures, the nerve to your eye, causing you symptoms. So it's slow-growing.
Okay. Are we going to test this? You guys will test the tumor for the cancer, right? If it's
Yeah. So
right away, the surgery.
we send during surgery. We send a small specimen to pathology. They'll tell us immediately, just do we have pathologic tissue? Okay. The hardest part after surgery is waiting for the final diagnosis. So it takes about probably 5 to 14 days for them to come back with an actual diagnosis. And then that way we can actually sit down with you and discuss what the tumor is and what the treatment options are, if any are needed.
Okay. I'm just writing for myself not to forget.
Yeah. No. Yep.
Okay, what do we have? So about
herniation.
Yes.
Yeah, we saw on the report there's a herniation going on
One of the artery.
It says there's approximately 3.5 millimeters subfalcine herniation. I believe it's.
That's just discussing the shift in the brain tissue in relation to the tumor. So the tumor occupies space and it pushes brain tissue out of the way. That's just radiology documenting. It's called mass effect, and it's pushing on the surrounding brain tissue. There's no bearing on the surgery or
I see.
or what this is.
Okay, is that tumor pushing on arteries and making any complications like any herniations or any bad things to those arteries?
Yeah, so it's definitely surrounding some of the major blood vessels to the brain. Typically there's usually a plane between the tumor and those blood vessels. Sometimes there are vessels that are traveling through the tumor that are at risk during surgery. So one of the major complications in relation to any type of surgery involving this tumor and location is a stroke, damaging some of those blood vessels that feed the brain tissue. Or typically, if we see any blood vessels within the tumor, if we can't safely remove the tumor off of the blood vessel, then we leave the tumor surrounding that blood vessel so that we don't damage that blood vessel, right? It doesn't do us any good if we get 100% of the tumor out, but we destroy the blood vessels and the nerves surrounding it. So that's why the upfront goal of any surgery is to remove as much tumor as possible that is safe. And we make that judgment during surgery as to how aggressive we can be with a resection, and we're preserving some of those nerves and blood vessels.
Okay.
So after the tumor will be removed, this herniation to the artery will be there permanently, or it will go away?
Yeah, no. The space that the tumor is in now, it'll just be a void space or a dead space. Over time, the brain may fill part of that space, but there may just always be a little cavity there. And it's not gonna. Won't be any issue. Just there's spinal fluid that bathes the brain.
Okay.
It'll just be filled with fluid.
Okay. Question about, you asked a lot of questions related to function of the pituitary gland. Do you think this, based on symptoms and images, do you think it's a problem. Especially I saw on the report, MRI report, that doctor didn't see the stalk, the because it's encased with the tumor.
I think, let me just double check here. I mean, it's definitely pushing on the pituitary glands, but I think I think I can visualize the stalk.
Okay.
The concern would be, I mean, this could be arising from the pituitary gland itself. Probably less likely since all your lab values were normal and just given the appearance and location. But there's always a chance that there could be some pituitary dysfunction after surgery just from manipulating the tumor off the pituitary gland.
Okay.
And that's something that we would watch for carefully after surgery.
What kind of complication can be because of the...
It can be, the biggest one would be sodium regulation. And so that's basically just, we'd be monitoring how much urine you're making, how much you're peeing, and then how much you're drinking as well. These are all things that we would just monitor while you were in the hospital. And then we just, there's 8 different hormones that your pituitary produces. So we would document those lab values before and after surgery just to make sure that there's no major fluctuations in those lab values. But basically, we've been looking at your cortisol and it's called ADH. It just regulates your sodium levels. Those are the 2 biggest ones that we monitor afterwards.
Mm-hmm.
Okay, and if it's gonna be not on the right level, then it can be fixed somehow, or?
Yeah, it's it depends on which hormones were affected.
Mm-hmm.
Unlikely it would affect all of the hormones, but it would just be a medication or 2 that you would have to take to supplement those hormones.
For life or for short period of time?
Sometimes they can be transient, and where you only have to take the medications for a short period after surgery. Sometimes it can be permanent. But again, it's something that we'll monitor afterwards and determine whether you need to take that medication or not.
Okay. So we're still waiting for the doctor.
I know.
We have more questions, but it's related to the surgery.
Correct. I don't want to jump the gun and tell you we're going to do a transnasal when he's thinking a craniotomy. So I don't want to.
Yeah, a little bit about maybe after surgery time and pre-surgery. What limitations we're gonna have? Like, can we fly? On the plane? Can we go hiking on a high altitude? So can we dive?
Yeah. Where do you live?
We live in Vancouver, Washington, Battleground, Washington, exactly.
Okay, all right. Yeah, typically the recovery from these surgeries is probably a day or 2 in the ICU. This is for both procedures that could be considered. And then if you need any recovery from surgery, a couple days on the floor. Since you don't have a whole lot of deficits going in, I suspect you'd have like a 2 to 4 day stay in the hospital in total. And that's about a 2 to 3 week recovery just from the incisions and just getting after surgery. You sort of get knocked down, so you sort of need to get your strength back. And then you're probably feeling like yourself at 3 months after surgery. I'd limit the amount of hiking or high altitude hiking that you would do in the first 6 months, just to let yourself recover and make sure that there are no complications. Another issue with any type of surgery is infection. So typically we watch out for those in the first couple of weeks after surgery. But it's not, you don't have to stay in bed for 6 weeks or anything like that. You're going to be up and walking on probably day 1 or day 2. And we'll have physical therapy and occupational therapy work with you as well.
So bending, lifting weights after that?
Yeah, I mean, lifting weights, nothing heavier than a couple pounds for the first 2 weeks until the incision is completely healed. And then once you feel like you're back to your normal strength, then probably by 6 weeks or so you can start lifting.
Okay.
what about before the surgery? Is it okay for us to do the hiking? Is it good idea or it's better not to do? Because we want to go camping by the Rainier, and we would like to hike there. Is it okay for me or it's not?
This is before or after?
Before.
Tomorrow, actually.
Tomorrow? It's probably okay. Yeah,
Okay.
I think that would be
Thank you,
fine.
doctor.
Yeah, that sounds pleasant.
Yes, yes. It's just 7,000 feet above the level sea. We don't know.
Yeah. let me email or text Dr. Frere to see if he'll be in shortly.
Okay.
How many cases a month, a year, similar cases you guys have?
Of these types of tumors, maybe 1 to 2 a week. These are fairly frequent tumors that we treat.
Okay.
And
Yeah.
how successful the surgery? So the surgery is done and the patient is
At least.
released from the hospital in 4 days. It's perfect, or those patients spending more time and there is a complication after.
Yeah. Again, every surgery, every tumor, every patient is different. I'll say overall risks of this type of procedure is upwards of maybe 5%. That includes infection, worsening vision, spinal fluid leak, rarely seizures. This isn't a benign procedure. Okay, there are risks associated with it. The risk of not doing anything, though, is that this tumor will grow, your vision will worsen, specifically in that right eye, can affect the left eye as well, and it's already causing some brain edema, and that can cause seizures. So I think the risks of not doing anything are much, much greater than the risks of the surgery. Okay, I can't tell you 90% of the time these are perfect cases. Everyone goes home. It wouldn't be a benefit to you for me to tell you that.
Okay.
There are complications with these types of surgeries for sure, but I think given this location and the tumor size, overall probably around 5%.
5% of
Not success. I mean,
Oh.
complications.
Of just having any type of complication.
Okay.
And that's ranging from infection, spinal fluid leak, seizure, stroke, and includes all of those.
Okay.
And then there are risks associated with anesthesia as well, right? Anytime they put you under general anesthesia, there's always a risk for the biggest three are stroke, coma, and death. Those are low and you're healthy, so those risks are much, much lower than if you were, say, 85 years old with heart disease and lung disease. So the fact that you're healthy makes you on the lower end of those risks.
Okay.
Good to know. And thank you for sharing that, because I know it's kind of hard to predict, but it gives us a little bit more comfort when we see these numbers.
Yeah, for sure. I just let him know that you guys are waiting for him. Yeah, and I don't want to say that, one, I don't want to scare you for surgery. I think surgery definitely needs to be done for this type of tumor given this location, right? The question is timing. Probably the sooner the better. It's not emergent. We don't need to do this today or tomorrow, but probably within the next couple of weeks it should be done.
Couple weeks.
Depending on what Dr. Frere's schedule is, and depending on what your schedule is, we can talk about timing.
Okay.
But then, these are tumors that Dr. Frere and our institution treats on a regular basis. We are experts in these tumors, and we do these on a regular basis. But even then, there are complications.
Okay.
But they're low.
Okay. One more question. I know that there, with the COVID precautions, only one person even allowed to visit the hospital. Uh, it's kind of distant from us. Am I going to be allowed to be next to my wife, and where and when?
Yeah, right now they are allowing visitors in the hospital. I think there's some hours, some visitation hour limitations, but for the most part, you're allowed to be there. There's now this new Delta variant. Things are changing, so there's always going to be a flux in the visitation hours. If we do schedule you and get you a surgery date closer to that date, we can give you a better estimation of what those visitation hours are.
Are visitors allowed in ICU?
I believe so, yes.
Okay.
Yeah.
I also have a question about paperwork. I need to sign the consent before the surgery. Is it possible for me to see these documents before the date of the surgery, so I can read it with a clear mind and at home to translate it? Because if it's gonna be given to me right before the surgery, I'll be very nervous and I will not understand completely. So
yeah, I think I'll talk with our colleagues here. Typically, I think you may need to come in for like a pre-anesthesia evaluation. And then at that appointment, we go over all the paperwork and consents before we actually see you for surgery. So I think you have to come in to get started.
Okay. And is it possible for me to be with my husband or with interpreter?
Right now, I think you are allowed to bring your husband.
Okay,
that's correct.
Okay, that's good. Also, I have a question about who is performing the surgery. I just want to be sure that the doctor is doing the surgery.
Yeah. No. So it is a teaching hospital. It's a residency program. There are residents. So residents are within the training program. I'm a fellow, so I finished my training program at an outside hospital. I'm doing a year of fellowship here. And then there's Dr. Ferrer himself. He just texted me.
Okay.
He's logging on now. Of all the cases that he does, he always does it with his residents and fellows. He is always present at all the critical points of the surgery. Sometimes I may open, and he may not be there when I'm opening the skin. But whenever we go into the microscope or we're doing critical points of the procedure, Dr. Ferrer does those procedures. So he is physically scrubbed in. He removes the tumor. He does all the critical steps of the procedure. That's Dr. Ferreira.
Okay. I just have been told by the bad experience the same procedure have been done here at OHSU, and I'm kind of scared. I want to leave. I have 2 kids, small kids, so I just want to be a normal person after the surgery, no complication.
You have kids, you said?
Yes, we have 2 kids.
How many?
2 boys, 12 and 7 years old.
Very good.
Yeah.
I have a 10-month-old,
Oh, nice.
first boy.
Congratulations.
He's a handful.
Yes.
Yes.
I believe you.
Yes, I hear you. I hear your concerns. It's very frightening and scary to be in your position at this point. I totally understand. Just know that if you do proceed with surgery with us, in our hands, we do these routinely. This is what we do almost on a daily basis. Our goal is to remove the tumor as safely as possible and get you back home with your husband and your 2 kids. That's the goal number 1.
It's a good goal.
Yeah.
Do we do as you said that we will be doing more MRIs after the surgery, right?
Yeah, so typically oh, here it goes.
Hi, Katerina.
Hello.
Yes. Hello.
Nice to meet you. I'm Manny Ferreira.
Nice to meet you
Sorry
too.
I'm a few minutes late. I took a little bit of time with the patient prior, but I'm yours now, and we're going to
Okay.
have plenty of time to talk.
Okay.
And is this
Dennis.
My husband.
I don't want to assume.
My husband.
And your name's Dennis?
Dennis, yes.
Great. Great to meet you both.
Thank you.
You met my star fellow, Dr. Miller here.
Yes.
I'm going to let him bring me up to speed and tell me where the conversation is. I pulled up the pertinent imaging, so I'm going to go over the films with you and everything, but he'll explain to me what you guys have discussed, and then you add, and then we'll pick up the conversation there if that sounds reasonable to you.
Yes.
Perfect. Thank you.
Okay. All right, Dr. Miller, hit it.
Yep, 39-year-old lady. Started developing visual symptoms back in April. Sort of has a right temporal veal. Oh, sorry.
Yep.
She saw her physician. They got pituitary labs. They were all normal. She has no other symptoms associated with this tumor. Sorry, I showed her the
film.
I showed her the films. I talked to her about potential treatment options, both transfemoral and craniotomy, and then left it for you to discuss what your options would be.
Great. Does that sound reasonable, Katerina and Dennis?
Yes.
Okay. So first of all, we're going to go through the images. I do believe that this is a tumor called a meningioma.
Okay.
This is not cancer. You're not going to die from it.
Okay.
And, if I have anything to say about it, I'm going to cure you of this disease. I'm going to do my best to try to remove it so that we don't, have to worry about it later in life. You're a very young person. I will tell you that that was probably the biggest concern is your vision. And I'll give you sort of a crash course in the anatomy, if that sounds okay. And then I'll show you some of the imaging characteristics that worry me, and that will lead to the sort of risks. Does that sound okay?
Yes.
We're going to start with looking at an image, and this is you looking at me, okay? And you're looking at me, and on this sequence, if I scroll forward, you can see. So here are your eyeballs, right? Mm-hmm. And if you're looking straight at me, we're going to start to go toward the back of your head. So at this level, this is the back of your nose, your left eye, right? Because you're looking back at me from the screen, and this is your right eye. And then these are the frontal lobes. The frontal lobes are the front part of the brain. And as I start to scroll back, you can see near your eyes. I start to scroll back, at the back of the eyeball, we're going to pick up where your optic nerves are. So these little bullseyes are the optic nerves that are coming out the back of your eyeball. And you could see this one has white around it a little bit more than the one on the left, right?
Yeah.
That white is spinal fluid. That's the consistency of water. Spinal fluid actually follows the optic nerve all the way out to the eyeball. That's why the optic nerve itself is actually considered part of the brain, part of the central nervous system. Why is there more water around here than over here? I think it's because of the tumor, to be honest. The tumor can actually trap spinal fluid so it can't go back and forth inside the brain. Okay? So as I scroll back, you can see there's still a lot more water around this nerve, right? Now you've almost, you can't see it anymore. But here, you actually have it all the way into where that nerve goes into the base of the skull. That base of the skull is called the optic canal. It's a tiny little hole that the nerve has to pass through that essentially has potential space. Now, in addition to that spinal fluid being trapped, and I'm going to show you another image in a minute, but your tumor, which is here, actually goes into that little canal.
Ooh.
That's why I think the spinal fluid is trapped in there, and that's certainly why you have that temporal field deficit, the inability to see your peripheral vision on that right side. Okay? Now, this is the tumor. The other thing, as I zoom this in, I want you to see, and why is Dr. Ferreira so confident that this is a meningioma? Number one, this is a very common growth pattern for meningiomas. Number two, this bone right here at the base of the skull is called the anterior clinoid process. It's almost about the size of your pinky tip, okay? And on the left side is the normal size of that anterior clinoid process. But if you look at the anterior clinoid on the right side, it's almost 2 to 3 times as big as the other side. You see that? This black thing here is about twice as big as that. And that is because meningiomas can cause the bone to turn over more. And that is a term called hyperostosis. So those two things together, including what I'm going to show you on the next couple of MRIs, lead me to believe that this is a meningioma. If this were a cancer, cancers grow very quickly. They don't have time to remodel the bone, and people don't come in with a little bit of their vision loss. They come in blind because the tumor is moving very rapidly, and the tumor can get inside the optic nerve and essentially kill it or give it a stroke. And that's not what's happened to you. Probably over time, the tumor is pushing on that optic nerve, and over time, it's remodeling the bone. Does that make sense?
Yes.
Okay. Now, if I now lay you down, now you're laying down, and your feet are coming out from the screen, okay?
Okay.
So again, this is a different sequence where the water in the eye, the spinal fluid in the brain is now black, but we've injected you with contrast, gadolinium contrast. So most of the areas you see in white are going to be areas that take up the contrast, okay? So this is a very normal picture. This is the tip of your nose. I'll window this just a little bit so you can see that. Tip of your nose, left eye, right eye. These are the muscles that move the eyeball. And then here, this black dot on the right and this one on the left are your carotid arteries. Those arteries are the arteries that feed the blood to the vast majority of the brain. And you could feel that pulse in your neck.
Yeah.
You don't see the tumor there below. And as we come up, you'll start to see a little bit of asymmetry. This, you could almost see, this side is a little bit different, right? A little more white here.
Yes.
Less white over here. This is actually the bottom of your pituitary gland. And if I scroll up, you could see now there's some mass here. And now you start to see the rest of the tumor. And this is your tumor. None of this white should be there. Rather than being, we use the tip of the pinky for the clinoid process, this is probably about the size of an egg, a large chicken egg.
The size of the egg? Wow.
And just for comparison, look at your eyeball,
Yes.
right? You could feel your eyeball and how big it is. This is probably about 2.5 of your eyeballs, maybe 3.
Wow.
Now that carotid artery, you could see on the left is here. On the right, you could see not only the artery, but maybe a branch vessel off the artery. And for Dr. Miller, this probably is the ophthalmic, right? Going into that optic canal. You could see it there. And Katerina and Dennis, when I told you that the tumor is following the optic nerve, here's the optic nerve on this sequence here and here, okay? But when I scroll up here, this is the back part of that canal. And you could see there's not only a little bit of tumor going into that canal there, right? But even the start of it on your left side. And this is a very classic picture, Dr. Miller, for a tuberculum cella meningioma. So these tumors usually arise from this mid portion of the skull base. This is actually bone here. And then they start to grow. And yours chose to grow not right in the midline, but off to the right side. Okay? And not to let the cat out of the bag, but any tumor that goes outside of the confines of the two carotid arteries, and you can see if this is the carotid artery on that side, and this is the carotid artery from below, about a third of the tumor is on the outside of the carotid artery. I do not recommend we go through the nostril to take the tumor out that way. So I always recommend a craniotomy. Sometimes for certain tumors, not meningiomas, but sometimes I will do a combined approach through the nostrils and with the craniotomy, because there's some parts of the tumor that are easy to get out through the nose and some part that are easier or safer to remove via the craniotomy. I'll get into the surgery, but you could see this is the top part of that clinoid process. It's not good enough that we remove all the white part of the tumor. I have to drill all that abnormal bone away. Why? Because if I don't, you're going to continue to lose vision in that eye, because that bone almost always has tumor in it. So I need to drill that off. That's called an anterior clinoidectomy and an optic canal decompression. I cannot do that through the nostrils. A very common subset of the patients that come to me from elsewhere in the country or the world have had a great surgery that's removed all this, but not an adequate surgery to open that canal and remove the bone. So their MRI looks great, but they continue to go blind in their eye. And they come to me and say, why is this happening? It's because there's still tumor inside that canal. Sometimes you can see it on the MRI, sometimes you can't. So yep.
May I ask you? So the canal, it's actually a bone structure, right?
Yes.
And you need to remove this part of the bone.
So the best way to think about it is it's a canal just like this, and my hand is bone. But instead of having normal bone, which would be my hand, it's thickened. So my hand is huge because of the tumor. And inside the canal is soft and bony tumor. So to get the nerve decompressed, I need to do this to the canal. So now it's open, and now your nerve can breathe, and that spinal fluid can go back and forth. And the way we do that is I use a combination of an ultrasonic device that's called a sonopet that doesn't transmit vibration as much as a drill would, and heat as well. It doesn't transmit heat through the bone as well. And I do this a lot. I probably do it about 150 times a year. So very experienced at doing that. In a young, healthy patient like yourself with good vision, I'm betting that your vision gets better. And within probably 4 to 6 weeks, you'll subjectively notice it. And the ophthalmologist will show us that that visual field deficit resolved. Radiation as a primary modality for this is not in your best interest as a first-line therapy. Radiation of any form, fractionated photons, protons, neutrons, or gamma knife or cyber knife, it's all toxic to the tumor, but also toxic to the brain. Two of the most sensitive parts of the brain to radiation are the optic nerves and the pituitary gland. You are less at risk in my hands, and I'm very optimistic that I do better than radiation by a lot as a primary modality. On occasion, we recommend radiation if I can't get the tumor out, or it winds up being a higher grade meningioma, which means that the pathology looks at it under a microscope and it's actually a little more aggressive, which is there's 3 grades. Grade 1 is benign, grade 3 is cancer, which you do not have, and a grade 2 is somewhere in between called an atypical tumor. I don't always recommend radiation, even if it's an atypical tumor. It depends on the extent of the resection and where I think I may or may not have left tumor, or where I think you may have tumor recurrence in the future. I think the chances of you needing radiation, or at least recommended by me, after surgery is probably about 1 in 10. Watching it for a healthy 39-year-old woman like yourself that has 40 to 50 years to live is not a good option. The natural history, we have a case on Thursday, Dr. Miller, where we'll see the natural history in somebody who's a little bit older than you, but it's not good. People go blind in one or both eyes if you don't address it early in the disease. Yeah.
Okay, and where incision is going to be?
Yeah.
If you would.
So we do not shave hair, okay? If you can imagine on my head, and I don't have hair, but I don't shave hair because I think that shaving it increases the risk of infection a little bit.
Okay.
So we actually part your hair. It's a little too short to braid, but we'll part it, and the incision will almost certainly be something that goes like this. And it's a long incision, just so that when we pull the scalp back, I could see the back part of your eye socket called the orbital rim.
Okay.
Now, usually the craniotomy will be eccentric to the side that the tumor's eccentric. In your case, it'll be mostly on the right side, but it may go across the midline just a little bit. And that allows me not just to see the tumor from this direction or this direction, but if I need to, this direction, right? Sometimes you need to manipulate whatever, the nerve, one of the artery branches from the carotid artery, or maybe it's going to be a blind view if I do a maneuver from this direction. Having all of these angles gives me about almost 180 degrees, right? And the other 180, if I need it, I do with the little cameras that I use to go through the nose, but I use them as an adjunct up here. That's pretty rare for a tumor like yours, but sometimes I do bring in the scope to look around corners. That bone, including the orbital rim, because I take that off as well, we put all that back on at the end of the operation with little titanium plates and screws. Besides having a black eye, because you will have a swollen black eye after surgery, cosmetically, you're going to be just as pretty and beautiful as you are right now. Surgery can take anywhere from 6 to 10 hours. Could be 4 hours, could be 15 hours, but 6 to 10 is a really good, guesstimate at the time it'll take. In the hospital, anywhere from 2 to 5 days, very common. The chance of you having some catastrophic event, like a stroke, going blind in your right eye, something really bad like that, I would put into the fraction of a percent. Really, really rare.
Okay.
The more common temporary morbidity risks are spinal fluid leak. I have to drill the bone from above. Sometimes if you look at this picture, this is looking at you from the side. This is the top of your nose. This is the back of your nose and throat. This black space is the back of your nose. That's air-filled space. When I breathe, air goes into this space. So when I drill the bone from above, sometimes I breach into the back of your nose. That's bad because we have bugs, bacteria, yeast inside the nose that can come into the brain that's very sterile. I'll know that if you start leaking fluid through your nose. If I see it at the time of surgery, I repair it. I put tissue there to keep the fluid from going through that hole. But that would be the spinal fluid leak I'm alluding to. Infection, the risk is about 1.5 to 2%, and that could be a superficial infection in the skin, all the way down to pus inside the brain, where we have to remove the bone flap. That's extremely rare. What we do to prevent that from happening is we don't shave your hair. We wash you. The night before surgery at home, you're going to wash your body with a disinfectant called Hibiclens to decrease your bacterial burden. And we give you antibiotics before, during, and after surgery. Temporary vision changes. Prepare now for having blurriness in that eye. That has nothing to do with me manipulating your nerve. It has everything to do with the swelling in the eye after surgery. That swelling isn't just in the skin and the black eye you see. That swelling also goes into the covering, the conjunctiva of the eye ball itself. So it always looks like you're looking through murky water, right? And that usually goes away by about 7 to 10 days after surgery.
Okay.
Sometimes people see double. It's rare, but it can happen. If that happens, that can last anywhere from 3 to 6 months, where your eyelid doesn't open like your other eyelid. It's just a little droopy, like you have a lazy eye, or your eyeballs aren't conjugate. They're just a little bit off, and that can be, result in this double vision I'm alluding to. Sometimes people can have numbness in the forehead or the cheek. That's rare, but it can happen. Subtotal resection. I may on purpose leave tumor that I think is too dangerous to remove. It's rare, but it can happen. Specifically, these tumors can sometimes go into the wall of arteries. If I see that the tumor does not respect the normal plane with the carotid artery and it's going into the wall, I'm going to leave that part of the tumor and live to fight another day. The MRI doesn't predict any of that. Sometimes I'm like, oh my God, this is going to be a mess. It's encasing everything, and we get in there and the planes are perfect. Likewise, I look at a film and say, likelihood I'm going to be able to cure and remove all of this. And I get in there and it's a mess, right? There's no substitute for what I'm going to see at the time of surgery based on the MRI imaging. But I never go into an operation not ready to cure a patient. I'm going in there to try to take out every speck of tumor without hurting you. So I always have that in mind. And I'll tell you, I have enough experience to know if my patient has a little white dot of residual tumor, but they're completely neurologically intact, they're much happier than a patient that has a perfect MRI, but is blind or can't move their arm or things like that. So that is just experience and knowledge that you have to trust me with at the time of surgery.
Okay. And my question is, I already asked Dr. Miller. So the surgery is performed by you and Dr. Miller.
Yep, with these two hands, all of these nuanced little things, I do 100% of the operation. Dr. Miller and my chief resident, so Dr. Miller is a board eligible neurosurgeon. He finished his residency in Washington, D.C. and is here for 1 year to gain experience on this complex stuff. He helps me with the opening and things like that under my direct supervision. But I am essentially doing everything under the covering of the brain, 100%. And, I do 400 operations a year. I feel very confident in my method where I'm training the next generation, but this operation's performed by me. And that's why people come here. No doubt about that.
Okay.
Talk to my community neurosurgical colleagues. They'll say, the intern's doing the surgery. I don't know any intern that can do any of this operation, right? This takes a long time to get really good at it. And, I'm one of the highest volume skull-based neurosurgeons in the world, not the country, not in Seattle, because on this coast, there's nobody that does the volume of surgery that I do for this type of disease. Zero.
Yeah.
Okay. That's good to know.
That's comforting.
And for you, Dennis, I look at her. Katerina is like my wife on the day of surgery. I have her in my hand. I'm going to treat her like she's mine.
Thank you.
Right? I'm not going to let people do things to her that I think are unsafe. I'm not going to do things to her that are unsafe, whether it's the janitor, the nurse, the circulating person, the anesthesia people, none of that stuff. So I am the captain of the ship when you trust me with her life.
Thank you. And we'll be praying for you.
Well, thank you. The last thing I want to show you guys is on this picture, this is called a flare signal. So it doesn't light up the fluid in white, but any inflammation or fluid in the brain, it highlights. And the top of your tumor is irritating the brain. Sometimes that could be that the tumor just got to a certain threshold. Sometimes it could be that the brain is inflamed or irritated because the tumor is pushing or invading the covering of the brain. That's called peel invasion. We don't know. But this can sometimes predispose you to seizures. So if you and Dennis say, you know what, we want to do this, but we want to do it in a month or 2 or 3 or 4, I would put you on an anti-seizure medicine and maybe even give you a prescription for low-dose steroid. Because if you started to have, if she got grumpy, Dennis, if she was just a little bit off, whatever it was, sometimes this flare abnormal signal can arise very rapidly and give those symptoms. So, I just tell you that because I noticed it, and I put you into a category where certainly I am not going to leave this consultation without telling you my recommendation 100% is for surgery and nothing else. The urgency is debatable, right?
Okay.
You have a visual field deficit it's not a 5-alarm fire, right? If you had come to me and said, I can't read out of this right eye anymore, I'd say, God, we need to do something within the next 2 weeks. But with this stuff, if I had my choice, I would say anywhere from 4 to 8 weeks is the timeline that I would recommend you get on the operating room schedule.
Okay.
I actually cannot read with this eye, to be honest.
And you've noticed that for how long?
So,
Because I noticed you saw an outside ophthalmologist. You haven't seen mine, right?
no, I saw 2 of the ophthalmologists, just the regular one and from the OHSU, and it have been 2 weeks ago.
Okay.
What was the reading? 600 or something?
No, the right eye was 400, and I saw only 1 letter on a 400 scale.
Okay, so that's very poor vision. I definitely want you to see my neuro-ophthalmologist, right? If you're going to have me do your case, because her name's Dr. Courtney Francis. I've worked with her for almost 12 years, my tenure here. She has some ways to look at irreversible or reversible damage to the optic nerve. And I want to know that. Obviously, I'm going to treat your nerve like it has every possibility of recovering, but I want to know how much irreversible damage she thinks. It's not a perfect science, but she's very good at telling me that.
Okay.
And that would happen if you're going to have surgery with me when you come up for the history and physical, right? The preoperative evaluation by my nurse practitioner or PA. We'll get all that in the same day. Because you haven't had a CT scan that I can see, have you?
No.
Okay. So that bone I told you that's thickened, I get a fine cut CT so that I can look at it and make a 3D model of the bone that I'm going to need to drill at the time of surgery.
Okay. Talking about scheduling, what's your availability?
Like I say, I book out about a month or 2. But if you guys say, Dr. Ferrer, we want you and we want to do it as soon as possible, I will find a way to fit you in within the next week or 2. Yeah.
Okay.
I don't want you going elsewhere because I can't accommodate you in my schedule is what I'm saying.
Okay.
So give me every opportunity. My office gives you a date and you're like, no, I'm going to go with this guy or this woman surgeon. Give me a chance to accommodate you. I feel bad when people go elsewhere and it may or may not turn out well, and then I see them later. So
Right.
so let me have a shot to get you on my schedule.
Okay. It's more administrative probably question. Who should we talk to about scheduling and
So Thomas and Tom
Okay.
handle all my surgical bookings. I will meet with them tomorrow morning. Expect a call from them by tomorrow afternoon.
Okay.
And I will tell them, please reach out to Katerina and Dennis, and they'll take care of everything, including insurance approvals, all that stuff.
Okay.
Okay, so we will be waiting a phone call from them
You bet.
tomorrow. Okay.
Okay.
Any other questions for me, guys? Anything?
Charles did his best to answer most of the questions. And I don't know. Do you have
What
anything?
kind of side effects can be after the surgery. It's complicated surgery.
It is. I think I gave you a very good picture of that.
Yeah.
You know,
Yeah.
of the risks, the things to bet on. Like you're absolutely going to have this black eye, pain when you chew, because I have to cut through this muscle. This muscle is called the temporalis muscle, and if you feel it when you chew, it's contracting, right? And when I cut it, we have to suture it back together, and that's painful. And sometimes people, I see them 6 weeks after surgery, and they can't open their mouth because they've been drinking through a straw and not exercising their jaw, right? So it gets all essentially atrophied. Like a weightlifter that doesn't continue to lift weights, the muscle gets smaller. You have to continue to do that. Chew gum, do your exercises, things like that. You're going to have a headache. You're going to be on narcotics for about a week, maybe up to 2 weeks after the surgery. Decrease, decrease, decrease. And also about 3 to 5 days after surgery, I allow you to start taking Advil, ibuprofen, Aleve, things like that thin the blood. So I don't want you taking that stuff right after surgery because I don't want you to have a hemorrhage or something. But 3 to 5 days, I let people start using that. And then you're going to be tired. You know, you look like you're in really good shape and health, but you're going to be healing from complex surgery. The anesthetic stays in your muscle and your fat, which you don't have a lot, but it stays there for about 3 to 5 days, and people just feel crummy. Sometimes really crummy, like they have a flu. Sometimes it's just, you know, they're taking a nap 2 or 3 times a day, and that's completely normal. I also operate on a lot of children at Seattle Children's Hospital with these diseases, and even little kids. I mean, they're tired for a week or 2 after the surgery. So just expect that. Lastly, I want to give you guys my email address. So take this down. Manuel, Manuel, F as in Frank, the number 3 at uw.edu. Manuel F3 at uw.edu. And that's my direct email. If you have any questions, concerns, we have to have another consultation like this. Whatever you want, don't hesitate to reach out. Give me about a day or 2 to get back to you. I usually will include my my team from the clinic to help me if there are things that I need or questions you have, things like that. But if it's an easy thing, I'll reply right back to you guys.
Okay, again, Manuel F3 at EW.
At UW, University of Washington. UW.
UW.edu dot
uw.edu, like education.
oh
Dot edu.
there is a dot.
Edu.
Okay, so there is a dot after W.
Yeah.
Okay.
uw.edu.
Okay.
Yeah.
Anything else?
I'm kind of scared.
I think that's a very normal thing, Katerina. Very normal. Obviously, I've never had neurosurgery on me. I don't want to give the impression that I don't empathize with you. I do. I want to give you confidence, though, that this is like another day at the office for me and my team. We do this all the time. And we're going to take very, very good care of you.
Okay, in case of complications, what's the backup plan and how we reach out back to you so we can address this urgently?
Like if the vision gets even worse and things?
Yeah.
Or the leakage, whatever.
Yeah, call the office. If it's a real emergency, you go to the local emergency room, right?
Okay.
If it's, you know, something I can get back to you within a couple of days, you email me. But if things dramatically change, you had a seizure or something like that, you go straight to the emergency room locally and you ask to be transferred, and my hospital will take care of bringing you to me.
Okay.
Yeah.
Thank you.
We do have an email, so we can reach him.
Yes.
By the way, you have been, I didn't know about you, but my pastor, Vitaly Rashko, he had 2 consultations with you about his tumor.
Uh-huh.
He recommended you.
Okay. terrific. And I know that he was recommended to me by somebody also in your church who had surgery with me. Yeah. No, it's a small world. That's very important for Dr. Miller to hear that too as he starts his career. I would say about 6-7 years ago, it became the reputation, right? With my colleagues, neurosurgeons and ophthalmologists, but more prior patients. Because, patients carry around a picture of their MRI, and when they hear it, and they'll show people, look, I had this removed by this surgeon, and people are like, my God, that person looks awesome. I want that surgeon to do that to me. And I take that very seriously, and it's a big honor and privilege and a feather in my cap when other patients of mine recommend me to colleagues and friends.
Okay, and I have this question. So your approach is go through the top of the head because of the size of the location.
Yeah, size, location, and the involvement of those blood vessels. So they're branches of the carotid artery that are really intimately involved, where through the nose, I just can't get there safely, especially around that hyperostotic bone, that big bone we talked about. Yeah.
So
and out of endoscopic versus open approaches, endoscopic's about a third of the operations I do. So it's a large volume, a third of 400. It's just your tumor doesn't enable me to do it as safely and as well as I can. Does that make sense?
Yes, it is. So when you go into the tumor, it's gonna be a brain in a way.
No.
No?
So these tumors arise outside of the brain. That's why we take off the eye socket, the orbital rim. I go outside of the brain to get there.
Oh, you're going through these holes of the eyes?
No. Removing this bone.
Yeah, no. So if I leave all that on, I have to do this and lift up the brain. If I take that off, it's just there, and we follow that little pathway. There's no going through the brain with a tumor like this. Yeah.
And you're gonna put the bone back?
Yeah, absolutely. That's my plan. I don't keep it.
Okay, what about the MRI? So if you're doing the titanium, it's okay to do the MRI later with these things?
Yep. So the titanium is MRI compatible forever and ever, and it doesn't trigger the metal detector at the airport.
Okay, good. All right. Wow. Thank you, doctor, for explaining and telling us
details. Yeah, we appreciate it. You're extremely busy, and spending time with us is rare.
No, I appreciate you guys waiting, and I'm going to say the same thing to the next patients we're about to see is, I'm a little late, but then I spend time with all of my patients. So it was my pleasure.
Okay.
Thank you so much.
Thank you.
Okay, guys.
Yeah. Okay.
Take care, and my office will be in touch tomorrow, okay?
Sounds good.
Okay, great. Thank you, doctor.
Thank you.
Thanks.
All right. Take care.
Bye.
Bye-bye.
Bye. Ого.
Большая. И еще залазит сюда.
Что он там померил? Две?
Он как яйцо сказал.
Ну, он как 2,5 раза больше, чем eyeball.
Он начал мерить с одной стороны 2,2, а тут 2,9 почти 3 миллиметра.
Сантиметр. Я себе 2,2 записала, да, а там было 2,9, да. 2,9 я видела цифру. И вот получается у той женщины тоже было 3 сантиметра, и они через нос тащили ее.
Что не нужно делать?